Production. Your moderator is North Idaho College political scientist Tony Stewart.
Good evening, ladies and gentlemen. For the next 3 weeks, we're going to be bringing you 3 programs on a very special and important topic to all Americans, that being mental health and mental illness. It is our viewpoint that this topic should be discussed in much more detail and depth than it has been in the past, and that is the purpose of these 3 programs. In program number 1, we're going to deal with such questions as, what is mental health? We also want to deal with the federal and state laws that govern mental health and mental patients and their care, and we're going to give great emphasis to what's going on at Eastern Washington State Hospital and its history. On show number 2, we will be dealing with the psychological aspects of this topic, and particularly emphasizing what are the different types of mental illness and how does one treat those particular illnesses. In program number 3, we will deal with the medical questions that are involved with treatment of people who are confined to mental institutions and their physical care. Joining us on all 3 programs will be personnel from Eastern Washington State Hospital. On program number 1 this evening, we have with us 3 guests. To my far right is Dr. Richard H. Humphreys, who is superintendent of Eastern Washington State Hospital. He holds a medical degree from the University of Oregon and also did his surgical residence at the University of Oregon Medical School hospitals. Joining him in being quizzed this evening will be Muriel K. Taylor, who is a doctor of medicine. She is also the director of the Bureau of Mental Health for the state of Washington. She holds her degree from Cornell Medical School. Our 3rd guest comes to us from this institution also, and that is Dr. Robert A. Wetzler, who is also a medical doctor and is director of clinical psychiatric care at that institution. We want to welcome all 3 of you. Joining me this evening in quizzing our guests are 3 panel members. To my far left is Barry G. Schuler, who is president of North Idaho College, holding a bachelor's degree in the field of psychology from the University of Minnesota, and his master's degree and his PhD work both at the University of Minnesota. Janelle Burke is on the panel. She holds a bachelor's degree from the College of Idaho, a master's in counseling from Indiana University, and for 5 years served as Dean of Women at Idaho State University. Our 3rd panel member will be Mr. Robert Singletary, holding a baccalaureate degree from Alaska Methodist University, also extensive work at Murray State, and a master's degree from the University of Idaho, and is a member of the faculty at North Idaho College. We'll proceed to questions at once, and the first series will come from Barry Schuler.
I'd like to address this question to Dr. Taylor, and since we are talking about mental health and the specific mission of the institution, Eastern Washington State Hospital, is dealing in this area, what or how do we define mental illness?
When we're talking about mental illness in the sense that the state institution is the major resource, we're really talking about the severe end of the spectrum. We're talking about psychosis, both depressive and schizophrenia. We're talking about also some problems that relate to sometimes offending behavior. The hospital serves, for example, as a resource to the court in terms of determining whether a person is competent to stand trial. It also serves as a treatment resource for those persons found not competent to stand trial, and sometimes it also serves as a treatment resource afterwards for people who the court has determined to be criminally insane.
And following along on that question, perhaps I could ask, in terms of the scope of the task that confronts a hospital like Eastern Washington State Hospital, is the incidence of mental illness in our society increasing? Is the job or the task becoming larger, or is it decreasing?
Well, I think probably that in specific terms, the incidence stays the same, generally speaking, from not only from culture to culture, but really from time to time when we're talking about severe mental illness. On the other hand, our problem in Washington may be growing, and probably across the country, because after the Second World War, lots of children were born, and they are now entering the age group and form a bulge in the population between 20 and 35, and it's that age group that has the highest incidence of severe mental illness.
Janelle Berg.
Dr. Humphreys, please tell us about the history of Eastern Washington State Hospital, how it began, and a little about the changes that are taking place there now.
Well, Eastern State Hospital was started approximately 80 years ago. It's sort of an interesting thing to me that well, I should say this first. I guess the hospital population reached a maximum of about 2,200 patients in 1955. I'm sort of interested in what happened between 1929 and 1955, especially when we reached our maximum population. We talk as though we had 2,200 patients at the hospital, but I'm never quite sure we had 2,200 patients. We had 2,200 people. In 1929, of course, the Depression came along. People were out of jobs. I was not connected with the hospital at that time, but I understand that the funding for the state hospitals was rather minimal. It was sort of old man on the totem pole for the overall national and state requirements when joblessness and poverty was really a great problem. I feel that a lot of people who came to the hospital from 1929 on during the Depression years, really the hospital acted more as a social agency, a poor farm, almost an asylum for people. I was reading over some of the old superintendent's reports back in 1905, 1910, and of course that was just before and subsequent to World War I, at which time this country had a large influx of transient foreigners. One of the reports in 1910, I believe it was, showed that out of 194 admissions, almost 50% of those admissions were people from Germany, Switzerland, France, Poland, and just about 50% were so-called American-born citizens. And sometimes in looking over some of the old records, you'll find a person who from Germany, from Switzerland, from France, from Belgium, from wherever, did something that was unacceptable in the community, and he was picked up and he resisted and struggled, and they brought him out to the hospital, and here he was all isolated. He couldn't speak English, he couldn't defend himself. There was a depression on in 29.
Dr. Humphreys, may we continue to move on? I know we have so much to do. And can we bring it up to date from that point? Where have you changed in the number of residents and in funding?
Right. Now, following the Depression, of course, I do have to say that we did get into World War II, and at that time we went on for a period of about 5 or 6 years when all of the professionals were gone. They were overseas. And so the hospital not only had poor funding, but also had very little in the way of professional help. About the time that ended, by sheer coincidence, I think, the new drug Thorazine came along. And so all of a sudden we had a change in the economic situation of the country, plus we had drugs to work with that we didn't have before. And from 1955, when we had a maximum of over 2,200 people in the hospital, to 1963, when I first went out there, only a period of 8 years, we had dropped down to 1,300 patients. Now we are down to 300, about 312 patients.
So you've dropped from about 2,200 to 300.
Right.
Thank you. Bob Singletary.
Dr. Humphreys, could you give us a breakdown of your administrative organizational structure and the major divisions and major areas of responsibility within there?
Yeah, the major parts of the hospital, we have an acute admission and treatment area where the newly admitted psychotic patients come, which is under the supervision of Dr. Riadika, who is a psychiatrist. Then we have a medical surgical unit where the patients are those who have certain physical incapacities that prevent them from participating in the more ambulatory wards. And then we have a unit we call the rehabilitation unit, which is sort of a combination of some of the inheritance we had of yesteryear, people who were committed many, many years ago, who became institutionalized, were more or less social isolates. They have few in the way of friends, families, anybody who cares about them. The other component part of the rehabilitation unit are those people who will be in the hospital and then they'll leave and then they come back again and they leave, and they are not amenable to the treatment modalities on the acute intensive treatment unit. We also have another unit which is basically concerned with the mentally ill legal offenders. These are people who because of being officially adjudicated criminally insane, or who because of their inability to assist in their defense and appreciate their peril are held legally on a stay of proceedings.
Barry Schuler.
Dr. Wetzler, how does one go about getting admitted to Eastern Washington State Hospital? What are the procedures that are involved in the different types of admissions that take place?
Before you answer that question, an oversight on my part, I did not give his background, his credentials. He holds a bachelor's degree from the University of Pittsburgh, and then he holds a medical degree from Loyola University School of Medicine, and has a very outstanding background. Dr. Wetzler.
The admissions to Eastern State Hospital, of course, we like the patient to be referred by a doctor first, or even second by the mental health clinic. The mental health clinic, we hope, will serve as a stopgap, if possible, that the patient doesn't have to come to the hospital, that they can be taken care of in the community. But if this doesn't occur, then the patient comes to the hospital and they are allowed to sign as a voluntary patient. The other way, of course, is to come as an involuntary patient. And if we want to get into that discussion, we would have to go into further details. But those are the two primary ways. Sometimes relatives bring a patient out, they're concerned, and the admitting doctor sees the patient, but we treat mentally ill people with mental ill problems, not the people with some drug problems or alcohol problems.
Janelle Berg.
I should like to ask Dr. Taylor if she might make some comparisons, significant changes in the whole field of mental health throughout Washington, such as length of patient stay in hospitals in Washington. How has this changed from years ago to today?
When we were preparing for the budget submission this year, I did a little kind of historical tracking. It really is kind of interesting to look. In 1955, our overall population was some 7,000 patients, and the length of stay about that time was 93 months. That's over 7 years. Our average length of stay nowadays is something like 16 months, and that's heavily skewed by the few very long-term patients. In both of our state hospitals now, in our acute admissions area, our average length of stay is well under 20 days and usually around 10. And we're doing probably as well in that regard as all the rest of our community facilities. So we're very proud of the change that has occurred in the use of the state hospital. The other thing that's changed is, in like manner, just as our length of stay has gone down, our state hospitals are now proportionately seeing more admissions for a short period of time and really serving as an emergency and crisis facility for the community. And we have proportionately less of the chronic long-term care.
How about the ratio of patient to staff? Has this changed?
Yes, it has, but it's a little difficult to follow. If you look back at the time that Dr. Humphreys was talking about, it's indeed true that the institution ran on its patients rather than on its staff. However, if you look back After the Second World War, it was very low staffed. Some 5 or 6 years ago, however, the staff was poorer than it is now, and I think that generally speaking, the staffing has progressively gotten better. We always find ourselves somehow feeling short-staffed, and there's somehow never enough to do what we think really needs to be done, but in fact the staffing has improved over the years.
Do you think that the greater number of admissions indicates a change in social attitude toward seeking help for mental health?
Yes, and not only does it reflect a change in attitude, but it also reflects a change in resources. In that 1955 period that I was talking about, the three state hospitals then saw some 2,500 admissions. Now our admissions are about 3,500, and we have in addition some 450 beds across the whole community that last year saw another 10,500 admissions. So whereas in the 50s, the state hospitals were, practically speaking, the only psychiatric inpatient resource, aside from those few resources that could take private pay patients. Nowadays, we're seeing something like, I don't know, 3 or 4 or 5 times the number of admissions across the state, and I think that reflects the availability of resources as well as a change in the attitude, seeking help when it's needed.
Are there statistics available to show that people are coming earlier in the development of a mental illness rather than later as the illness is progressing?
I don't know the statistics, but that's surely the impression. Perhaps Dr. Wetzler and Dr. Humphreys have a feeling of that.
I would think this is generally true. People are becoming more aware of mental illness, that there's availability of treatment, they have crisis identifications, and these people do seek help much sooner. They don't hide them in the back door.
Yes, an interesting thing was, I can recall in several years ago when, especially one of the older patients would be sent to the hospital, the family just brought all of his belongings out. We had a room where we put all of we even had outboard motors and trunks and motorcycles brought to the hospital. And when Grandpa went to the hospital, it was adios. That was the end of him. Now they're finding that Grandpa can come out to the hospital, be treated for a short period of time, and go home again. And we retain the family contacts rather than let the family think this is the end of the line for him. Or even the younger people, the same thing is true.
I would like to interject a question here before we move to Robert Singletary. In an earlier conversation with you, Dr. Humphrey, some weeks ago, I noted that when you have to deal with funding, and I think this is important in relation to this question, you must face a legislature in which you must use such statistics as that at one time you treated 2,200 patients and now you treat 300. They immediately ask you, I'm sure, as conscientious legislators, how can you justify increase in budget when you're actually having fewer patients? How do you respond to this kind of criticism? Or what I'm also getting at is this question of the frequency of admissions, or where you have people coming 2 or 3 times a year for short periods rather than permanent. And that does not show in your statistics in relation to budget items. How do you respond?
Well, I think it takes a little bit of mathematical figuring. When we were admitting, when we had 2,200 patients in the hospital back in 1955, the admission rate to the Eastern State was about 400 a year. So we were admitting 1 patient for every 5 in residence. Now, with 300 patients in residence, we're admitting approximately 1,000 patients a year, which is what, 3 to 1. So we've actually had a 15-fold increase in admissions to inpatient residents. And if anybody's been in a hospital lately, they know that it's the first few days of admission in the discharge process that is expensive. And so you can't equate the need for budgeting to the in-resident population. The relationship of budgeting should be to the treatment programs, and this is a battle that Dr. Taylor's been holding for us in Olympia for a long time, but it's difficult, I think, maybe Dr. Taylor knows more about this, to get the legislators to appreciate this fact, because they still have a tendency to want to budget according to in-resident population rather than activity.
In other words, what we're getting at is that the number of permanent, so-called permanent residents is much lower but the actual number of human beings you're treating has increased significantly.
Right, yes. And it's pretty cheap just to warehouse patients.
I think the important thing is the type of treatment they're getting is much
Yes.
more intensive, the medication in a one-to-one group therapy. A variety of therapy are being given, and this is why we need a large staff.
And those types of very special treatment are much more expensive than past history.
Yes, and I think another thing, too, the whole area of health processes, including mental health, is becoming far more sophisticated. Eastern State Hospital, for example, for the last 14 years has been fully accredited by the Joint Commission on Accreditation for Hospitals. We have Title 19, we have HEW, we have just a multitude of agencies that are surveying us, PSRO, utilization review. Well, all of these things require more staff time, even though we have fewer patients in the hospital.
And not only more staff time, but much more record keeping and accountability.
Paperwork.
So it has to show on paper that, in fact, we have much higher expectations of the treatment process.
Bob Singletary.
I would like to key in on that, your word there on accountability, which seems to be something that many institutions are involved with today. And I think maybe our listeners might be interested in some background on the types of professional standards, certification standards, licensing qualifications of staffing of various types. Could you give us some background on that? Maybe Dr. Taylor or either Dr. Humphreys.
Well, well, for one thing, and to me one of the most important things, for the last 10 years, there has not been a physician or a psychiatrist at East State Hospital who is not fully licensed to practice in the state of Washington. Many years ago, this was not true. We're finding that by having the approval of the Joint Commission on Accreditation for Hospitals, we are getting a much higher quality of all professional staff. The psychiatric nurses, the psychologists, the social workers, the activity therapists, the occupational therapists. And not only that, but by doing this, the hospital has a very prominent part in being an educational part of the whole community. We act as the psychiatric training facility for all of the licensed practical nursing schools in the country. We have students as far from Indiana in occupational therapy. We have the speech and hearing therapy department that is associated with Eastern Washington State College, and we have students taking internships there. Just recently, just this last year, a new thing was added, and Washington State University School of Pharmacy, who is now starting a doctorate pharmaceutical program, are utilizing our hospital as one of the rotating internship experiences for their doctorates in pharmacy. So all of these things are being added, which takes staff time, and the more that staff time is taken up, the less staff time there is to take care of the patients, and therefore the greater the need we have for more staff.
For instance, in paraprofessionals, is our licensing involved even?
Sir?
Licensing of paraprofessionals that work with them?
It depends on your level, your description of paraprofessionals. We include licensed practical nursing, for example, among our licensed professionals. We do have several classes of unlicensed personnel. They fit in the treatment care staff too.
Barry Schuler.
On the funding of the operation at Eastern Washington Hospital, is that principally state funding, or do you get a substantial amount of federal funding that aids each year? And then also, does the individual, if he has the financial ability, does he make some contribution to his own hospitalization? How is the funding derived for the total operation of the hospital?
We currently fund the hospitals out of the state general fund primarily. However, the hospital, because of its accreditation, is also, and we also collect, the state collects, for example, Medicare and Medicaid funding from those patients who are eligible and have that kind of coverage. We also collect at the state level from insurance companies, and patients are responsible for covering the costs of care when they're able. Interestingly, until the next biennium at least, the hospital does not get its own reimbursements, so that that money goes into the general fund, but then the hospital's own budget is in essence stable because it comes out of the state general fund.
Janelle Berg.
Could you please explain the relationship between the community mental health centers and the state hospital and the total mental health program in the state of Washington, how that works into the community projects?
Sure. Washington's kind of an interesting state because we're sort of both ahead and behind. In Washington, we had really superb mental hospitals. When I came to Washington in 1968, it's outstanding as a state because we had very good mental hospitals, and that was at a time when around the country many states were in fact closing state hospitals, withdrawing funding from state hospitals, and returning patients to the community. That's happened here too, of course. However, the other piece that goes along with that is that the community mental health system in this state was not as developed as it had been elsewhere. We lost many patients, I think, not lost, but we moved many patients from the state hospital facilities into facilities that probably really were not ready to accept them, and the skilled nursing facilities were the most readily expandable. And at the time that many of those patients were moved initially, the community programs knew nothing about how to take care of them. So we are now in a kind of catch-up situation where the community mental health programs are getting really to be quite competent and interested in dealing with our state hospital patients, and we are now beginning to be concerned about all the residential programs that function between the state hospital and the community mental health programs.
Where are the community mental health programs situated? Are they in each county, or is there a district?
Every county, our law gives each county the responsibility for setting up mental health programs. Counties may cooperate, and in fact a number do, so that we have several multi-county programs, but the funding goes out county by county and in a per capita fashion.
Are the counties responsible then, who is responsible in the county for the mental health program? Is that the county commissioners, or is it in fact your office from
the county commissioners sign a contract with us, and they are responsible for promoting the program. We do set standards, and the law designates the services that the county may choose to provide.
Mr. Singletary.
Dr. Wessler, would you review some of the major legislation, both state and federal, regarding rights of patients, commitment act, those types of things? Would you mind covering some of the major?
There are so many factors involved in the question you ask. Let's perhaps divide it in two ways. One, that the primary purpose of any hospital is to provide treatment. So then the patient has the right to treatment, and this is what not only the mental health clinics, but the state hospital, they provide treatment. Number two, this has been something that was, in terms of right to treatment, is something that's been going on since about 1964, when Judge Bazelon decided that a patient needed treatment. He couldn't be housed. In the state of Washington, we have the commitment law, the involuntary commitment law. It's perhaps a offshoot from the fact that the patient has a right to be in the hospital, not to be in the hospital, to be treated. Briefly, the patient is seen by the mental health professional, sent to the hospital if he refuses to go as a voluntary, seen and held for 72 hours. A 14-day hearing is held where he's committed for 14 days, and then we escalate 14 days, 90, 180 days. But the most important thing about the commitment and the laws is that these people have all their rights. They are no longer declared incompetent. They can be involved in a treatment program. They have a right to attorney and things of that nature.
Does the state of Washington or any other state that you know of, or either the federal for that fact, have legislation requiring that mental health centers or hospitals provide some sort of transitory residence for people that are being discharged, people who really still basically need some sort of support?
I think the new law is going to cover that much better than the present law, the House Bill 288. Anyway, the new law, I think, will cover what we call, has been mentioned, the revolving door type of patient that's coming in and going out, that will not enter into a program. We cannot commit people unless they're gravely disabled, can't take care of themselves, they're dangerous to themselves, they're dangerous to the other, or they've committed some sort of act, murder, anything that's dangerous to people. So these people then are handled primarily through the mental health professional who sees them first. And then either they have to go to a treatment center, Sacred Heart, Eastern State Hospital in the Spokane County. And then in the 17 counties that Eastern State Hospital covers, there's one other in the Tri-Cities area.
May we clarify one more point on this area? Is it not correct, I believe I heard this in doing research for this program, that once someone is committed to your hospital or any hospital in the state of Washington, that to keep them confined, you are required, you alluded to this, I believe, but I want to get more specific, you are required to give them treatment or you cannot hold them. Is that not correct?
We are required to give them treatment, but the question of holding them is not the problem, really. If we can't treat them, we want them to go. In other words, if they can be handled better in the community, their resources are available, we let them go. If they are not treatable and reach maximum hospitalization, then we want the patient out. So you say, we don't hold them if we can't treat them. Well, let's put it the other way around. We want to treat them, and then if they're well enough, they go. Am I answering your question?
Well, I'm trying to get even more specific. I would like to know what the content of the law is. Does it require you to do this?
The law requires, in the 72, they call it ENT, Examination, Evaluation, and Treatment. Then a 14-day, there's a 14-day period of treatment. And then we go from 14 to 90 days. And during the 14 to 90 days, these people must be treated. The law also requires, if they've been in there 180 days, we review every 6 months their treatment programs.
We are required, though, if not by ethics, certainly the latest Supreme Court decision that I know of relating to a patient in Florida requires that the hospital and state hospital programs provide some kind of active treatment program which is dedicated to helping a patient achieve some more normal status.
Okay, one more question in this area. I'm speaking of the state of Washington. Under state law and any federal court decisions or guidelines that might apply also, once you have an individual committed to, for example, Eastern Washington State Hospital, what kind of guidelines or provisions are there today that specifies what you can or cannot do in relation to that patient, if voluntarily or non-voluntarily?
Well, in the involuntary commitment law, there's a relatively specific list of patient rights and things which we can and we can't do as treatment physicians. One of the things that we must do is to provide some kind of physical assessment as well as a mental status kind of examination, and we do that and we provide medical care in the hospital setting. There are some limitations on practice. They have to do with imposing something upon the patient. So restraint or isolation, medication, all of those are in the law, regulated in particular kinds of ways. Physician signatures, physician orders, and a frequency of supervision. Further, the law requires particular procedures related to the administration of shock therapy and prohibits psychosurgery.
May I ask one more question? Is this something that is rather uniform throughout the United States, or is the state of Washington ahead of most states in that area?
We think that the Involuntary Treatment Act is probably a model, and it seems to be the model that many states are now looking to in rewriting their own acts. I don't know about the specific provisions that you just asked in that regard, but the whole of the law is supposed to be a model.
Yes, thank you. Barry Schuler.
To continue this line of questioning, there's a concern expressed by some in our society, and probably partly from the law enforcement agencies, that the commitment procedure or process has become so difficult that it's becoming impossible for them to protect society from the dangerously disordered person. Do you share that concern? Is that concern justified? Is the elaboration of this whole process with all the built-in protections for the individual, is it complicating to a degree where it maybe deserves concern, the hospitalization of the dangerously or potentially very dangerous person?
Well, I can say that we are certainly concerned, and we see some difficulties with the current law. We hope that the amendments that we've proposed to the Involuntary Treatment Act will help in some regard. And what we've asked for is a court mechanism for extending a period of medication subsequent to hospitalization. One of our experiences is that a patient comes in and is successfully treated in a short period of time, and then one lacks the kind of criteria that you'd need to hospitalize the patient for longer, but most patients have the most of their side effects from medication early on, and those diminish after a month or so. So our experience is that patients come in, are successfully treated, don't qualify for an extended treatment period, go out of the hospital and go off medication because of the side effects. And we are asking for a 90-day extension period to do something about that. The other problem, though, beyond the problem of the dangerous patient, has to do with patients whose behavior is really not acceptable in the community, but who are not covered under the involuntary program. And I think part of that is a systems failure rather than a law failure. We have not really developed across the board adequate funding for providing those kinds of intermediate services and an ability for the community mental health programs to outreach so that there is really accessible service for folks who are unwilling and difficult.
I think there's another thing that comes into the overall picture, and that is that I don't know very few illnesses where a physician really cures a patient. The patient has a great responsibility. If you have a diabetic patient, certainly you can control his diet, you can control his insulin, you can get him in perfect shape to leave the hospital after he comes in diabetic coma. But if he leaves the hospital and doesn't follow his insulin and doesn't follow his diet and goes back into diabetic coma, you don't blame the hospital. And I think that's an area that to me I'm very sensitive about, because many times I get asked the question, how come the guy has to come back to the hospital? Why do you let him out so soon? Well, when we let him out, he was in perfect shape. But if there's not a shared responsibility by the patient and his family or other interested people, it's like an ulcer patient. He gets tired of eating soft-boiled eggs and mush, and pretty soon he wants to go on some French fried potatoes and a steak, and his ulcer comes back again. And I think it's a very comparable thing, and I don't know how you're going to legislate the fact that this person has got to take his medicine unless something like Dr. Taylor mentions can be brought into the law, where when he is discharged, there is some kind of an ability to say to him, by golly, you go back and see that you do get your medicine. Because if he doesn't do it, he's going to come back again.
I think one important thing is that not all mentally ill people are dangerous, and I think dangerousness is a hard thing to define or describe. And I think most crimes that are committed are not primarily committed by the mentally ill.
They're committed by your next-door neighbor.
Or something. And I think also when Dr. Taylor mentions about treatment, that the new law, if it passes, will require the patient when he leaves the hospital to get outpatient treatment. This will be one of the requirements of the new law.
This is state law.
This will be a state law that will require him to have some follow-up care so we don't get the revolving door in and out. So this is very important in terms of treatment.
It used to be that our return rate was approximately 30% of the patients that we left. Now it's about 65%. And it's simply because we're unable to hold a patient there for treatment unless they conform to the criteria Dr. Wetstra mentioned. And even though they are psychotic, if they're not dangerous to themselves or others or gravely disabled, we must let them go out. And maybe the treatment isn't completed yet.
Janelle Burke.
It would appear to me that one of the major concerns of many patients would be the record keeping. And I wondered if you might indicate how you go about record keeping, what the confidentiality is, what the patient's rights are in regard to the records that are kept at the state hospital.
Well, the first legal requirement is that we cannot inform anybody except those individuals who are involved in the Civil Commitment Act that the patient is in the hospital. So it wouldn't matter if a wife would call up and she hasn't seen her husband for a week and wants to know is he at the hospital. We couldn't tell her that. So the presence of the patient in the hospital is the first degree of confidentiality. From that point on, we can release no information about that patient to anybody except whomever he has written down on a piece of paper he gives us permission to release information to. Now, there's a few little minor exceptions with some of the legal people if it involves transfer, I think, to another state or another sheriff or something saying as that, we can give certain pertinent information. But an example of that came up the other day when I was confronted by a man from the FBI from Seattle who wanted information about a patient who had written a threatening letter, threatening to kill somebody, and wanted to know what I could tell him about him. And I said, well, I can tell you nothing about him. And if he's made that threat, then the only suggestion I can make after I consulted with our Attorney General was that you go ahead through the legal process and prosecute him for making a threat to kill somebody. And then, if the defense attorney wants to bring up the mental illness aspect of it, then he can do that then.
What rights does the patient have to see his own records?
I think there came out an article the other day on that. The records, I think legally, are pretty well definitely decided to be the property of the hospital, not the patient. However, the patient does have the right to see his record unless, in the opinion of the therapist, information in the record would be harmful to him. I think that's about the only exception. But
What we try to do if they ask to sit down and discuss what's in the record with them or read parts of it, let them know what we're doing. But patients now are involved in their treatment program. They know medicines. They are asked to sit in with a team. They discuss it. As far as the records are concerned, we're required, Dick, aren't we, to keep certain records for accreditation, certain forms and so on and so forth. So there are a lot of paperwork that's involved in this.
with this new PSRO, we have to have criteria for admissions listed out. We have to have documentation of certain intervals,
Reasons for treatment.
Justification for treatment. Why is the patient getting this? Why has this been recommended to the patient? Also, if a certain treatment is recommended and the patient refuses, which he has the right to refuse, we have the responsibility of informing him of the consequences of his refusal to accept treatment.
In other words, what we are saying from this discussion is that the movie One Flew Over the Cuckoo's Nest, that certainly is not the case in Washington law, and court decisions restrict personnel not to treat them in that way.
Not only that, but we've learned something about that really from the civil rights thing, and that has to do with this issue of whether patients really are engaged in their own treatment process responsibly or not. And it turns out that your successes are certainly improved to the extent that patients do begin to take responsibility for their own behavior changes, and certainly understanding and knowing the record and participating in the process as more of a peer equivalent to staff is a part of what we've learned in the treatment process.
The important thing is trust and faith and hope.
Robert Singletary.
I would like to open this up to the three and deal with somewhat of a philosophical situation concerning the overall concept of institutionalization itself, in particular large institutions. I had an opportunity to do just some cursive reading on Ralph Nader's Mental Health Task Force. And they believe basically that mental health care should belong entirely to the social services, except, of course, when there needs to be medical intervention. And that alternatives should be preventive care, better crisis intervention, use of teachers, police, ministers, nurses, and that psychiatrists and psychologists should be used basically as a consultative capacity. How do you react to that, and how do you see this as being a trend?
Well, the Nader report was kind of two ways. One, they were very critical of the fact that the community mental health program were not doing a very good job with serious mental illness, and that they should be. And on the other hand, they also went through this model, which is in fact exactly the historical model that the community mental health programs have tended to develop along. So it's a little hard to respond to that simultaneously. I think that it has been shown that for chronic patients, and I'm now just reading a good book about this, that for chronic patients, there is certainly a medical component that's necessary, and that has to do with medications and so on. But the more normal, the more a part of ordinary society those people can be, and the more they have an opportunity to interact with non-patient society, it looks like the better results you can attain. So I think we will, if we really get involved in doing a good treatment model for chronic mental illness, which I would maintain we have not yet achieved, I think it will have a lot more in it of the socialization model that you're talking about.
I think there's one thing, of course, being a surgeon and not a psychiatrist, and I tend to be a little organic in my thinking, that is medically organic. There has to be a responsibility of the person for whatever illness he has. And I don't think it would matter how many chest surgeons you developed, as long as people keep on smoking 10 packs of cigarettes a day, you're going to get cancer of the lung. And as long as the United States subsidizes the tobacco business, that even makes the problem more complicated. As long as people keep on drinking alcohol, you're going to have alcoholism, and you're going to have alcoholic deaths. And as long as people don't know how to have automobiles, you're going to have crashes on the highway. So you can legislate all you want and write these nice theoretical books, but if the patient himself doesn't learn how to conduct himself in whatever manner he should, something's going to happen to him.
But getting back to your question, I think it's entirely true. The trend is that the paraprofessional people, the social, the policeman, the fireman, the teacher, counselor, all these people have an interest in, and they are doing in some way, in the mental health communities and schools and other areas, they are doing treatment with people on a one-to-one basis or in a group, because they're giving the patient, again, the support that they need. But they still need, as doctor says, we still need the mental health, or we need the expert in order to treat the medical component that is present in the mental illness. And these people are not qualified to do so.
Dr. Humphreys, I think it's very appropriate and important before this program comes to conclusion, we don't have too much more time, for you to tell us a little bit about what you're doing at your institution in relation to the tax dollar. I understand that on a comparative basis with other hospitals that are not mental hospitals, that the care is about $90 per patient. Is that on a...
Not at our hospital.
I know yours is about $48,
yeah,
but I'm saying a regular hospital is about $90 a day.
Basic room rent about $90. Then you start adding the extras, and you get up in quite a bit higher than that.
But in your case, it's $48 for total, I believe.
Yes. I think really the taxpayer gets his money's worth out of the state hospital, because the roughly $40 per diem includes not only his room and his food, it also includes all of his medications. It includes any laboratory work that is necessary. It includes any x-rays that are necessary. It includes speech and hearing therapy tests. It includes electroencephalographies. It includes the professional services of the physician, the psychiatrist, the social worker, the psychologist. So all of those are rolled into $40. And I think when you take a $90 base charge at a private hospital I had a knee operated on here a year ago, and 6 days cost me $1,600. And you know, you get billed for the aspirin tablets, and you get billed for the crutches that you use for a half a day, and all these things. So I think $40 a day for the total comprehensive care is extremely reasonable. And I might say that is, we do not charge that. This comes out of Olympia. They prorate it, depending, as I understand it, on the person's income, the number of children he has,
the ability to pay,
and his ability to pay. So it may go anywhere from the full $40 to nothing a day.
Okay. Something very important in relation to that. And for this kind of price, what are you able to provide? What I'm asking is, how many medical doctors do you have in your staff? How many psychologists, psychiatrists, and RNs, and so forth?
We have 16 physicians, of which 7 are psychiatrists, because we do have to recognize that psychiatrists are basically physicians also first. We have 4 psychologists. We have 36 registered nurses. We have approximately 100, more or less, licensed practical nurses. We have 13 social workers. We have a staff of, I think, 10 or 12 in occupational therapy and activity therapy.
I must emphasize how important a role the social workers do play at the hospital. I think sometimes we forget this, and they do play a very important role.
Yeah. As a matter of fact, most of the treatment modalities that are used are done on a multidisciplinary group in which the physician, the psychiatrist, the psychiatric nurse, the social worker, the occupational therapist all play a part in putting input into their feeling about the patient, about his diagnosis, about his treatment, about his potential for discharge.
Very sure.
Since we're from Idaho and you're from Washington, my question is, are there arrangements for interstate cooperation? It would be very easy, of course, for someone from North Idaho to be over here when he had a problem that would cause him to be hospitalized for a breakdown or something like that. Is that person normally then transferred back to his home state for treatment? And how is it done? And also perhaps previous hospitalization that's taken place in Washington, there are certain records that might be relevant to a future hospitalization in another state. Is there interstate cooperation?
Yeah, now you're asking sort of 2 questions I hear. Number one, any patient who is traveling through the state of Washington from another state who becomes acutely psychotic can be hospitalized at one of the state hospitals for a short period of time. Now, they haven't defined a short period of time, but we assume that means until we can get in touch with the home state. But we can admit patients from other states. If patients are in, let's say, Eastern State Hospital, and they have a family in Idaho, and they want to have that patient back in Idaho, then there is an interstate compact where the people in Idaho will write to the responsible people in Washington, and we will arrange for a transfer of the patient back to Idaho, or vice versa. So there is a mechanism for that. Thanks.
Janelle Bird.
I should like to ask about juveniles in the state of Washington. Where are they, those who have mental problems, where are they held, or where are they taken for treatment?
We have one state facility located on the Western State Hospital campus for 32 youngsters. It's called the Child Study and Treatment Center. It primarily serves children who are referred by the courts all over the state, and often by the juvenile courts rather than coming through the involuntary treatment commitment process. That facility is really more dedicated to the chronic treatment of very difficult failure children who have gone from one piece of the system to the other. And it does not serve the major gap that we have in Washington, which is we really have no acute inpatient services available to youngsters across the whole state. We are very hopeful that the legislature will address that problem in the coming biennium. And as well, we are beginning to develop a series of child-related services through the community mental health programs and beginning to look sidewise at our links into the residential treatment center programs.
There really is no place then for the autistic child to go.
Yes, there is specifically. Interestingly, in Washington, autism is a part of developmental disabilities. And so we have an institution, the Olympic Center, which does provide programs specifically for autistic youngsters.
Robert Singletary.
In both, speaking both nationwide and here at Eastern, what do you feel are your major limitations in dealing with mental health, and maybe possibly personnel or facilities or research? What do you feel are?
Well, personally, I think there's two major problems. One has to do with the community and the legislative attitude toward mental illness. How important is it? I get a feeling, with a little bit of paranoia, that mental illness is sort of low on the totem pole in most people's tax and budget attitudes. And so I think our budgeting is restricted. For example, the average hospital in the state of Washington, the average general hospital, has a patient-staff ratio of about 3 to 1. We are just about 1 to 1. If you look at psychiatric hospitals in general throughout the country, you'll find that the private psychiatric hospitals have almost 3 times the staff-patient ratio the state hospitals have. So I think that's point number one is hopefully someday people will recognize that the people who do become psychotic are doctors, lawyers, attorneys, professors. I mean, it covers the whole socioeconomic group of the citizenry. And it isn't just one small group of people who become psychotic.
What you're saying, Dick, is that we need education and we need money.
We need education and money. And what we need are more professionals.
Yes.
Is the attitude changing of the citizens, and is that helping you in this combating mental illness?
Oh, yes. Yeah, I'm sure that at least in Eastern Washington, I see acceptance of behavior on the part of people that 20 years ago would have been sent out to Eastern State Hospital. I think the public is far more tolerant of what we used to call aberrant behavior.
With that, we're going to have to bring our program to a conclusion, and I want to express a very deep and sincere thanks to all of you for giving us this most informative information. Ladies and gentlemen, on part one of our program, we've been dealing with what I would call the administrative aspects of mental health, the laws and the budgeting, and how we attempt in the state of Washington to deal with this question. Please be with us next week on part two, when we will deal with the types of mental illness that we must combat and how we treat those. And then the week following that, when we will deal with the physical problems and the medical care. I hope you are finding this series most informative. And until next week, when we will deal with the types of mental illness, I wish you a good evening.
The North Idaho College Public Forum can be seen at this same time each week over this station. The preceding student production was brought to you by Videotape Recording. Good evening.